What will you do if the cardiac monitor suddenly showed reading changes and the lab just reported an abnormal potassium level? What will you prioritize and why? Let's find out right now. In this 15-minute session, we will go through a clear, practical, and NCLEX-focused review of electrolyte imbalances with quick keys and clinical clues that show up again and again on the exam. So get ready, because mastering these details can be the difference between guessing and confidently choosing the right answer. Let's start with the basics. Why do electrolytes matter so much? Electrolytes like sodium, potassium, calcium, magnesium, chloride, bicarbonate, and phosphate keep our cells balanced, regulate heart rhythm and muscle contractions and nerve function. And the NCLEX, they are not just asking for normal values. They want to see if you can recognize the symptoms and prioritize and act quickly when something goes wrong. Always remember the nursing priority rule: ABC, monitoring, labs, and fix the cause. Let's see the first and most dangerous, potassium. The normal range is 3.5 to 5.0 milliequivalents per liter. When it's off, the heart is in danger. Hyperkalemia is when it's more than 5.0. The common cause is renal failure, acidosis, potassium sparing meds like AC inhibitors or ARBs, high spironolactone, and the symptoms are muscle weakness, paresthesia, arrhythmias. The EKG shows tall peaked T waves and widening QRS, a red flag for cardiac arrest. The next NCLEX priority is the step 1. Stabilize the heart with calcium gluconate IV. It doesn't lower potassium, but it prevents fatal arrhythmias. Step 2. Shift potassium into the cells with insulin plus these drugs, or sometimes nebulized albuterol. And the step 3, remove it from the body with resins, loop diuretics, or dialysis if needed. A quick rule: stabilize, shift, and remove. Never give potassium IV as a direct push. That's an instant cardiac arrest scenario on the NCLEX. Now let's talk about hypokalemia, less than 3.5. The causes: vomiting, diarrhea, diuretics, or alkalosis. The symptoms are clear: weakness, constipation, arrhythmias. You wave some EKG. The priority is monitor EKG, give oral potassium if mild, or IV only when necessary. Always diluted and never as a bolus. And remember, if magnesium is low, potassium correction won't work until you replace magnesium too. Sodium, the one that affects the brain. The normal values are 135 to 145 millikelvins per liter. Let's see hyponatremia. The causes are had excessive water intake or diuretics. The symptoms are confusion, nausea, and seizures. If severe neurological symptoms appear, priority is airway protection and slow correction with 3% hypertonic saline. Do not correct too quickly. It can cause osmotic demyelination, it's a brain damage. A safe rule: no more than 8 to 10 milliequivalents per liter per 24 hours. Now let's talk about hypernatremia. The causes: dehydration, diabetic insipidus. Symptoms: thirsty, irritability, and seizures. And the treatment is: start with isotonic fluids if the patient is unstable, then switch to hypotonic solution or free water. Again, correct slowly to prevent cerebral edema. Calcium, wounds, nerves, and heart. The normal value is from 8.5 to 10.5 milligrams per deciliter. Let's talk about hypocalcemia. The causes are hypoparathyroidism, pancreatitis, and massive transfusion. The symptoms are muscle spasms, tingling, and positive chest tag or trousseau signs laryngospasm. If respiratory distress or laryngeal spasms, you have to give calcium gluconate IV immediately. EKG may show prolonged QT. Now let's talk about hypercalcemia. The causes are hyperparathyroidism, malignancy, and immobility. The symptoms are weakness, constipation, and arrhythmias. The treatment is given IV saline hydration plus loop diuretics like furosemide to flush calcium out, and biphosphonates for cancer-related causes. EKG may show short unit QT. Mnemonic you have to remember is bones, stones, bronze, and psychiatric overtones. Bone pain, kidney stones, abdominal pain, frequent urination, and mood changes. Magnesium keeps muscle and heart calm. A normal value is 1.7 to 2.2 milligrams per deciliter. Let's begin with hypomagnesemia. The causes are alcoholism, vomiting, and diuretics. The symptoms are tremors, muscle cramps, arrhythmias like torsade points. The treatment is magnesium sulfate IV with close monitoring and reflexes and respiration. Let's move to hypermagnesemia. The causes are renal failure or excessive magnesium, often in OB. Some symptoms are like looser reflexes, bradycardia, and respiratory respiration. The treatment is to stop magnesium, give calcium gluconate as antidote, and end dialysis if it's severe. An NCLEX tip: if magnesium is low, potassium and calcium won't correct until you fix magnesium first. Finally, phosphorus, the less common but important in renal patients. Hypophosphatemia is have muscle weakness, respiratory failure, or you have to replace carefully. And the hyperphosphatemia, usually in renal failure. The causes low calcium, you have to use phosphate binders or dialysis. Let's review NCLEX general clues for electrolyte questions. Anything that affects the heart or breathing is priority. Always put the patient on a cardiac monitor for potassium, calcium, or magnesium imbalance. Never ever give potassium IV fast. Calcium gluconate is your emergency stabilizer for dangerous potassium or magnesium changes. And correct imbalances slowly unless it's a life-threatening situation. Let's review some quick practice cases. Case 1. You have a patient with potassium 6.3 with a Piketty waves and renal failure. Which is the priority? Give calcium gluconate IV, monitor EKG, and then insulin plus dextrose. Let's see the case 2. You have a sodium with 118, confusion, and no seizures. Which is the priority? Restrict fluids, correct slowly, and no hypertonic saline yet. And the case 3. You have an OV patient on magnesium develops no reflexes and slow breathing. Which is the priority? Stop magnesium and give calcium gluconate IV. You know that for the NCLEX and for your professional life, the patient education is so important. So always teach your patients to report palpitations, weakness, confusion, or seizures. Know which medications affect their electrolytes. Keep up with lab tests. And finally, adjust diet depending on their imbalance. For example, limit potassium in renal failure. An in-class strategy reminder: when answering, always ask yourself, first, is the patient life at risk right now? Second, is the heart or airway affected? And third, which action civilizes first before treating the cause? If you do that, you will handle electoral questions with confidence. That's our quick but complete review. And remember, mastering electrolytes isn't just for tests, it's for saving real lives. If this review helped you, join our community of nurses in the USA, where we were sharing NCLEX practice cases, simulations, and professional opportunities. Save this video and share it with your classmates, and follow us on our platforms to keep learning together. See you in the next section, and may no lab value ever surprise you on the NCLEX.